Okay, well, welcome to the 9th March webinar organized by the Jewish Medical Association. It's a great pleasure to introduce Jason Strelitz for many reasons. One is that, of course, I've known him for longer than I've known any of the other speakers. Secondly, we've shared a kind of work colleague. And so I asked my former work colleague, who has now been working or was planning to work with Jason, about what I should say as introduction. And he said, well, there's a rare phenomenon. Jason Strelitz is the rare phenomenon, a director of public health who has been absolutely outstanding during the last year and done a remarkable job, number one. And number two, the last conversation that this man had with Jason, Paul Brickell had with Jason, was a conversation when they were going in a car, and Jason said he just had to stop going where they're doing what they were doing because there was something funny about a respiratory infection that he had to attend to. So we could subtitle a year and Derek in Newham, East London, and what it means for the future by something funny with a respiratory epidemic. Respiratory infection that you had to attend to. Jason.
Thanks, David, and really great to be here and have this opportunity. I will just say that the second thing that you said there is absolutely true. The first bit I would challenge, because I think there have been just amazing directors of public health colleagues all around the country throughout this year who I think I've got the most amazing colleagues who I've learned so much from this year. It's a wonderful opportunity. This has been an extraordinary, crazy, emotional roller coaster of a year. It's been for everyone. It's been for my kids. It's been for everyone's families. But as a director of public health, it's been personally and professionally just an extraordinary year. People ask kind of what percentage of my job, friends ask, what percentage of my job is COVID? And still at this point, and of course the answer is pretty much everything. But it's constantly varied within every single day, from surveillance and outbreak management to testing and contact tracing, vaccination programs, community engagement, working with care homes on infection prevention and control, writing guidance, supporting schools, places of worship, finding, distributing PPE, mental health, food poverty, digital exclusion for children who are learning remotely and for older people who have no access to advice and support, immigration rights for people with no recourse to public funds, homelessness, diabetes, obesity. The list goes on and on and on, and everything through a COVID lens. I spend my days briefing politicians, supporting my amazing team, working with our communities, speaking to peers across London and nationally to stay informed and lobby on what I think needs to be done to better support the community I work with. And this is the first time really that I've stopped and really reflected on the past year. And so, yeah, it's a really nice opportunity. And it's a nice opportunity to be invited by David, who I've known a long time. And also just briefly, because I know that there's strong connections between Newham and the association. And every time I go to Newham Hospital to meetings in education, the Alan Naftalin Education Centre, I think of Alan, who I knew well, never worked with, but know of the strong connection that he had with this association. So what I thought I would talk about in a few parts, a bit about Newham for those who don't know this parts of East London, the story of the epidemic from where I've sat, and some key moments. Everyone will have their key moments throughout this past year. These are some of mine. Some reflections on why Newham has been hit so hard by the pandemic. A little bit of some examples of how we tried to reduce the risk. There are so many things I could talk about, but I'm going to just touch on a few. And then I'm going to finish with something about the future. One thing that I feel a little bit conscious about giving this talk is I'm going to talk a lot about risk factors and a lot about challenges faced in this community, but I spend my days and weeks talking with many members of our community, many of our residents, and the last thing they would want me to do is portray a community of misery and despair. Newham is, just one part of London, a bustling, energized part of London, very young, very good schools, very entrepreneurial in spirit, and lots of thriving community life. It's a great place to work, but the challenges, of course, are real, and the factors I'm going to discuss are real. But I thought it was important to say that. So a little bit about Newham first. It is a community of communities. The official census data, which is now 10 years out of date, we all received our censuses in the last week, has Newham with 73% of its population from Black, Asian and other minority ethnic communities. More recent data that I've seen suggests it's closer to 85%. And it is people from all over the world. As this chart shows, there are, in Newham compared to London, which of course London itself is so far more diverse than most of the country, there are more people from Bangladesh, more Black Africans, there's a long-standing Black Caribbean community, many Indians, many from Pakistan, many Eastern Europeans, people from literally all over the world. There's no one dominant community. It's a place of religions as well, and religion is a big part of life in Newham, and in that same census data, a comparatively small number of people describe themselves of no religion. And if you go around Newham's high streets, there are many mosques, many churches, temples, and other places of worship. It is also a community of many languages, with a relatively small percentage of people for whom English is their first language. And we'll come on to that later. But many different community languages. The government calculates something called the index of multiple deprivation, collating a range of factors around social, economic, health, to rank neighbourhoods in terms of what it calls multiple deprivation. Almost all of Newham's residents there in a northeast London live in the most deprived third of neighbourhoods. So that brings together a range of data, like I say, from employment, income, health, crime, other factors. So that's the reality. Most of Newham's neighbourhoods are in those bottom third. And like I said, it's a fast growing and it's a young population. There's greater poverty and lower economic resilience than in much of the country. That goes hand in hand with having that's why one of the major drivers of that the high levels of multiple deprivation. So a larger percentage of the workforce in those occupational groups, the lower paid occupational groups, and average wages, which are quite a lot below average wages for London as a whole. And that manifests in all kinds of different ways. So that's a bit of a picture of Newham to start off with. So the pandemic, how's it been? Well, around the time that I probably had a little bit before I had that first encounter with that David mentioned in the introduction, on the 31st of January last year, I had my first proper minuted meeting locally about Newham, where we'd heard enough to have a conversation. And of course, we had no idea. We had no idea what it was like. Everyone, we had no idea what was coming down the line. But it was on our radar. It started to be significantly on our radar. We started to dust off our pandemic flu plans and think about what this might mean. Then February half term happened last year, and the first cases started to be reported. And what happened right at the beginning was that directors of public health would get a phone call from Public Health England to say they had a case in their patch. And I kept waiting day upon day for that phone call to come. But not many Newham residents went skiing in northern Italy last half term, or wherever those first many cases were seeded from. And actually, by the time the first case was reported to me the first case was reported in Newham towards the end of February, there were already so many cases that they'd stopped calling directors of public health to tell them about individual cases. And then a few days later, we had the first reported death in Newham. That, of course, was the beginning of the first wave, which rocketed up and really, I think, hit us all as we were still trying to understand what on earth was going on as a country, as a place. Well into that first wave, you know, the cases having seeded a lot during that mid-February, and then spread throughout the end of February and throughout March. The first lockdown began in towards the end of March, with really, you know, COVID-19 having really spread rapidly throughout the community. And lockdown happened, and a few weeks later, really, if only a few weeks later after that first lockdown, the cases started to come down quite rapidly. The first Nightingale was opened. It's significant for me, but because it was next door to my office, the Excel Centre next door to the Newham Council offices. So really conscious, and I'd you know, see it as it came about. But really also conscious of it because that sense of it was being opened and so many other things were just not in place at that time. And lockdowns, so the case has come down. So this actually, what I've done here is I've charted mortality. Charted mortality because I can't because we didn't have case data for the first wave. So it made more sense to chart mortality. So obviously lagging a bit the case rate, but mortality came down quickly as well. And then in May, about mid-May, what was for me really the most significant day for me in the whole pandemic. The ONS published for the first time a report on standardised mortality rates by local authority. And sadly for me, Newham, where I work, where I'm the Director of Public Health, was atop of that table with the highest standardised mortality rate at that stage. It was an incredibly sobering day for me, reflecting on, you know, we had known that we'd been hit hard, but it really put it front and centre in a very, very deep and powerful way. I knew and I know that there are many factors that underlie that, and I'll go on to talk about them. But it was a very difficult thing to read and to see, very impactful for the community. And in many ways made me reflect that that first wave had really happened to us. Like I say, we were just trying to understand, really come to terms with what was going on. And as the first lockdown happened, and quite quickly, the case rate subsided and the mortality would follow. And we didn't have tools to deal with it as directors of public health. We didn't understand hugely what we were facing. And I remember deeply that weekend, I think the report came out on a Friday, and I called the mayor of Newham, who's directly elected mayor, Roxana Fiaz, who's I guess, the person I'm first and foremost answerable to locally. And I called our chief exec and I phoned them both up that weekend. And I chatted about it, and we talked about the impact of that report. And we said, we don't know where this pandemic is going to go, where it's going to take us over the many months ahead. But can we all agree that we will do absolutely everything we possibly can from this point going forward to support our communities to navigate this in every way possible? And they agreed, and I'll go on to talk more about that. So we went on into the spring and into the summer, and the case rate stayed incredibly low, but bit by bit, tools began to be added to our toolbox of how we could actually combat COVID. It wasn't until the end of June. Obviously, there was no community testing at the beginning. And for some time, the only community testing was for drive-through testing centres. But over half of the population of Newham don't have a car. So it took a lot of advocacy and arguing about it. And finally, we got our first walk-to testing centre in East Ham towards the end of June. And more people in the borough would be able to start to get tested. Next, a big moment with the Black Lives Matter protests, and really all of the data that had started to come out about the disproportionate impact of the pandemic on Black and Asian and minority ethnic communities, and that intersection with the Black Lives Matter movement was very powerful and impactful, particularly in a place like Newham. As we go on through the summer, towards in August at some point, as Director of Public Health, we started to get data. We started to know about cases. That's how long it had been through the pandemic before we had a really good granular understanding of where the cases were in our community, and are able to take much more targeted, or attempt to do much more active surveillance and take much more targeted action of what was going. And shortly after, we would start to do local contact tracing and start to work with NHS Test and Trace. The case rate stayed almost with very, very few cases at all, and no mortality through the summer. And then towards the end of the summer, the case rate started to creep up. Different factors, summer holidays, eat out to help out, the return to school, and slowly the case rate rose through the autumn and into the early winter. But really, we thought that things were going to be okay through the winter. We really did. Although the case rate was rising and we were concerned, we looked at some of the eye-watering case rates in some parts of the north of England, and thanked our lucky stars that things were going okay, and that this was going to be a hard winter with normal NHS winter pressures with this added on. But the vaccine program was going to start, and we get through it okay. And then the new variant hit, and it came in to northeast London, and our case rate just skyrocketed, absolutely skyrocketed from the beginning of December. And I watch and I look at the data every day, and it was terrifying seeing the rate that it was just going up and up and up. And really concerned about what the guidance was at that time around the guidance for Christmas, what the government would decide about lockdowns, and just seeing the case rate go out of control. In the first week of January, we had 5,500 confirmed cases in Newham alone. To put that in perspective, in these days round here, when it was quite high, and where we're still thinking about going into some form of lockdown, there were a few hundred, and we're back at that kind of level. We had 5,500 cases in the first week of January. In that point, the first vaccine was delivered in Newham, and obviously that was a time of hope, but it was really at that time masked by this absolutely escalating out of control case rate. From the beginning of January, it started to come down, and I look at it every day with hope and expectation, and see that it is still coming down, and that's really positive. But it was pretty scary, I have to say, through that period, and and our colleagues working in acute care have had the most, as we all know, the most extraordinarily hard time through that period. We've just had the milestone of reaching 50,000 vaccines, and that's where we are now. Things looking more optimistic, constantly nervous, having been through this journey, through this year of ups and downs, not knowing what's around the corner, not knowing what more surprises lie in store for us. But for now, things looking more optimistic, things looking more positive. So that's the first bit of what I wanted to talk about. That's the epidemic from where I sit as the Director of Public Health in Newham, and some of the key moments. So why is it hit Newham so hard? So just to say, on top of that, when I last looked at the ONS data, which looks for the whole period of COVID, having the impact of both the first wave and the second wave, Newham is once again, we dropped down a bit, but Newham is once again the local authority in the country with the highest standardised mortality rate for COVID since the beginning of the pandemic. And it's hit us hard for all kinds of reasons. You know, it's hit us younger, as this shows, this is from the first wave, but a larger proportion of our younger population died as a result of COVID than in the country as a whole. So it's hit us really hard. When I think about the impact on Newham and the way it's hit us, I think about it in three primary ways. I think about the risk to our population of exposure to the infection, the risk of becoming seriously unwell, and the risk of the wider impact on health and well-being. And I'll touch in a bit more detail on some of these. So in terms of risk of exposure to infection, the density of our population, the occupational risks our communities face, low car use, overcrowded homes, and just the fact of London. You know, we were hit first time round, and we were hit first with the new variant, particularly in northeast London. In terms of risk of becoming unwell, the high prevalence of underlying health conditions, the inability to shield, barriers in access to help, other factors linked to ethnicity. I don't think we fully yet understand all of the factors leading to disproportionate impact on certain groups, and even factors that there's been research on around things like poorer air quality. But then, of course, there are significant impacts, wider impacts of the pandemic that really intersect with both the health and social barriers faced in our community. So to touch on a few of these a bit more, I talked about occupational risk. This is some research that's been done on the left-hand side on the relationship between area deprivation, so that same indicator of multiple deprivation, and the ability to work from home, and showing an incredibly strong correlation that in deprived areas, simply far fewer people work from home. You know, I know this from my own life. The people who I know largely who have to go into work are people who work in the NHS and people who work in schools. The vast majority of the rest of my friends and my community are working from home. But those, obviously, the highest risk occupations that the ONS have showed for COVID mortality in social care, in factories, in transport, security, restaurants, nursing, all jobs that can't be done from home, all jobs that are done much more by people living in deprived areas. When we've done research that came out of our local contact tracing, asking people what gets in the way of isolating, and this was done with a view to thinking about people responding to engaging with test, trace and isolate, but I think has much wider implications. The number one fear is people losing their job. If I'm going to isolate, I risk losing my job. I am in such precarious employment that I risk losing my job. And it's been recognised in recent report to SAGE of the financial barriers to isolating, and that's massively true. And when it comes to test and trace, it means we're asking people to make impossible decisions between paying rents and putting food on the table and doing what they need to, taking the public health action of isolating, or even getting tested for fear of the consequences of what they might have to do if they test positive. These are just some examples from some of our, and I'm not going to read these all because of time, but these are from our local contact tracing service. I spoke to a couple who mentioned they need help with rent payment as the husband is self-employed and they've never claimed any benefit and they don't know what to do. The wife is feeling really distressed about it. I advised her about applying for council tax reduction and gave her a link from the handbook about help with rent. These are the real difficult choices that people face in low income, precarious, low to moderate and medium income and precarious employment, and that's so prevalent in London. Then there's housing. London has twice the rate of overcrowding in housing of the rest of the country, but Newham is way, way up there compared to the rest of London even. You know, these are conditions in which people cannot do anything but be risk exposing others to spreading the virus. Particularly pernicious and difficult when we have people out and about working in jobs that they can't do from home, and the very common reality of multi-generational housing that we have in Newham, and the risk of spreading it to those at risk of becoming most unwell. In terms of morbidity and those becoming most unwell, of course, this is from Michael Marmot and shows that relationship between life expectancy and healthy life expectancy in area deprivation. And Newham's neighbourhoods there in the circle, where healthy life expectancy is so much younger than in so many other parts of the country, and that vulnerability to COVID that we all know about from underlying health conditions. And in particular, the particular cone, and this is from the ONS report linking COVID mortality with underlying health conditions, and the particular prevalence in a place like Newham of obesity, diabetes, hypertensive diseases, which are so prevalent in our population and therefore and so impactful for COVID risk, and therefore have contributed to the high risk in our local population. And then there is the wider social impacts. At times during this pandemic, out of a population of 353,000, there have been 100,000 people in our borough on furlough or some kind of out of work benefits, an extraordinary amount. And on top of that, many people under the radar. This photo is of a food bank that's put on Twitter by something called the Newham Community Project, who support thousands of international students currently who base their plans of studying in the UK on being able to pay for it with occasional work, which has just disappeared, and I've just been left stranded. We have about 10,000 people in Newham with no recourse to public funds at all. Another huge challenge. So that's just a very quick overview of some of the risk factors that we face. So the questions we've asked ourselves, and when we put out our pandemic response, we worked on our second phase pandemic response plan after I had that conversation with the mayor and the chief executive back in May. We asked ourselves, what are the things we can do to reduce the spread of the infection? What are the things we can do to reduce the risk to those at most risk of severe outcomes? And how do we mitigate the wider health, social and economic impact of the pandemic? And there's so many things I could talk about, but I'm just going to touch on a few. The first is about supporting isolation. So in wave one, there was a particular challenge. People will remember the shops were empty. There were limits on what you could buy. There were big queues. Lots of people needed to shield. The shielding cohort was huge in that first wave. And I really worry, how on earth were people going to get access to basic support of food, prescription, psychological support? We made a decision even before shielding was formally announced that we were going to reach out to every 70-plus-year-old living on their own in the borough. It was over 30,000 people. We mobilised a huge proportion of the council workforce to phone them and ask them, did they need any? Did they have people that they could rely on for support, or did they need support? We developed something called Help Newham, which was our service to deliver food, prescriptions, and befriending support during that first wave. And at its peak, it was delivered 7,500 parcels of food in a single week. That was on top of many others who were being supported by many of our charities, faith and other community organisations in the borough, and by mutual aid groups working in different neighbourhoods in the borough who'd mobilised amazingly. As the pandemic's gone on and people were more able to access those things, and better systems were put in place so people could get protected delivery slots and things like that, the challenge changed. First, in terms of people's the poverty and increased isolation in the borough, and how could we meet those challenges. But then, as what I was talking about in terms of how we could support people who needed to test and isolate. And that's become a much stronger feature of our work. How do we support people who face that impossible decision about how they can isolate from work? We've developed a whole really transforming our contact tracing service locally to be a COVID support service, really reaching out on day one to our residents, trying to build trust, build that connection, and offer the support we can, which is mobilizing some financial support, some of that practical support, psychological support, and even offering alternative accommodation for people living in overcrowded or multi-generational homes, free supported isolation away from their home. And we're still on that journey, trying to do more in that space and understand how to have most impact. But there's a significant gap. There's clearly a significant gap in policy making, that people on low to medium wages, people who are self-employed, who simply can't work from home, still face an impossible choices. And I think that's something that needs to be resolved. The second thing we thought a lot about through coming out of the first wave was around how we engaged with our communities. We hadn't done enough, given the diversity of our population, the language challenges, and just the, how many are disconnected from, weren't hearing all of the advice. We had to do more. We developed a whole range of approaches, but a big one has been our COVID-19 health champions. We've got over 500 of these lay members of our community who just want to make a difference, who we built, who decided to work with us. We provide them with, we do multiple Zoom events every week. We cascade information through WhatsApp and Facebook. They spread the word in their communities, to their families, their friends, colleagues, churches, mosques. And then they feed back to us, what's going on? What are the challenges on the ground? What do we need to be doing more of? Where do we need to be focusing our energies and our efforts? Like I say, we use Zoom, we use WhatsApp, we use infographics, very simple infographics to cascade information through Facebook and WhatsApp and we've done hundreds of these different infographics translated into all of our main community languages. There's the Bengali, how to keep each other safe. And these are some of our champions, and they are the most varied people from across our community, all united by wanting to make a difference, wanting to help out. And they do their role in so many different ways, many through their faith communities, many through their school communities. Some send the information to every mosque in the borough. Some print it out and post it up in their windows so passers-by can see. And for me, when I go on these champions calls, not as often as I would like, they are the most inspiring, engaging, uplifting events. And I learn stuff every time. I hear from our champions about the things we need to do, what's going on, what's the pulse of the community, what do we need to do more of. And it was through those conversations in early November that we quite early started to do that engagement around the vaccine, and we needed to, and we knew we would need to. And this data is really recent. The uptake in our inner East London population is not where we want it to be so far. And there are big differences amongst different minority ethnic communities in our borough, and take up varies enormously. So we need to do a lot to work with our communities and work with our NHS colleagues to ensure there's effective access to the vaccine in places that people feel confident to go, and that we build the trust and confidence of our communities to take up the vaccine. We've developed what we call our supportive conversations framework. We started really early in December, coming out of the champions feedback, to have community meetings, honest, non-judgmental, hearing what are the regular things that are coming up, what are the concerns, answering every question we can, bringing together public health, local clinicians, academics from University of East London. We even had someone from one of the vaccine companies come and do a Q&A. really understanding what the barriers were people were facing, and learning how to have a really good quality, honest conversations. We've developed vaccine peer supporters. So many of our community are now volunteering to have training in having active listening, having non-judgmental conversations, and those 10 things that keep getting asked and how to answer them. We're not asking them to be experts, but to be another voice who can be actively and confidently promoting vaccine in the community. But it's not just about building confidence, it's about ensuring that access is in the place where people want to go. And I'm, spent this afternoon talking more about how we can to get more vaccine closer to where people are in the community, where they feel really confident to take it up. We've already done pop-ups in an evangelical church, in a mosque, a Hindu temple, a Sikh Gurdwara. They're really good, but we have a massive scale challenge that we need to achieve to vaccinate our population. And we know that it might get harder, even harder as we get through to some of our younger people. And we've just done a schools vaccine poster competition, and these are two of the winning entries. So we're doing everything we can to try and reach out and build that confidence in our communities. Wow, what a romp through this, and I've already got to the future. So where do I see things now? The COVID challenge. How do we stop COVID becoming endemic in areas like Newham? I know many colleagues of mine in the north of England, in areas that face similar challenges, are equally worried about this. Those occupational challenges that we face, the housing challenges that we face, the vaccine challenges we face. What can we do locally? But what do policymakers need to do as well to really ensure that, as hopefully the country is able to get past this, we don't leave certain parts of the country like Newham with a long-term challenge. We've got the recovery challenge. The social and economic damage of this has been devastating. Many more people out of work than in other parts of our city and our country. Many children really suffering in education. Lots of stories of people, large families in small flats, limited opportunity to work, limited screens, children studying, looking at a parent's smartphone. How do we Newham is a place which actually has really good educational outcomes. Has schools that have risen to the challenges, and aspirational communities committed to opportunities for their children. But this has been an unprecedented challenge, and how do we ensure it doesn't have a long-term scarring effect on our children, young people? And then there's the health inequalities challenge. These challenges, the underlying health inequalities that have left our community so vulnerable to COVID, have been with us for a long time. It's why I went to Newham in the first place. It was one of the reasons why I wanted to go be a director of public health, to really take on these challenges, and they've been laid bare. They've had a spotlight, incredibly bright spotlight, shone on them by this pandemic. And how do I use the opportunity, the commitment that my local politicians, that our local NHS, that schools, businesses, many more widely feel to tackle these issues? How do we translate that into some long-term gains for our community? We had been working before COVID, as I'd come new into the job, on a new health and wellbeing strategy for the borough. We were nearly there when COVID hit, and in the summer, in that downtime, we managed to finish it. And we eventually launched it at the end of October, and 300 people from across our community, from community and voluntary sector organisations, from schools, from businesses, our NHS colleagues joined for the launch. And when I'd gone back to the draft that we'd written and to think, is it still relevant in a time of COVID? I reflected that it couldn't have been more relevant, not just because it was about health inequalities, but all of the issues that we focused on in this 50 steps document, from mental health to immunisations to living wage employment, diabetes, air quality, physical activity, healthy diets, housing, and equal access to services. All of those issues which are through this strategy have been so laid bare, are so important by COVID. It was absolutely the right strategy, and it's our basis for where we go next. So I just wanted to finish by sharing one more time a short film, just 1 minute. Where is it? Where's it gone? Here it is. David, will you nod when if you can hear the sound, so I know that you can hear the sound? Has it come up, the YouTube picture?
Picture's there, but I can't hear the sound. There.
Being online makes people feel connected and it breaks down barriers.
We want to ensure that people with disabilities are included in our drive to make Newham more physically active.
Everyone should have access to food they need to be healthy. Together as a community, we can tackle food poverty in the borough.
No child should get ill or die from a preventable infectious disease.
Now more than ever, we all need to improve our health. Now is the time to act and make a difference.
In Newham, we're launching a new health and wellbeing strategy, 50 steps to a healthier borough. The scope of the 50 steps is very wide. It has to be, in order to put the foundations in place to build a future that will impact everyone's lives. Together, we can make a difference. Whatever your role in the community, there's a step for you.
What's your step?
I think I'll stop there. Thanks very much.
Well, first of all, I wanted to say I think I'm speaking part of everybody really. That's quite inspirational, and particularly that last bit, and quite a remarkable example. There are a couple of question about the health champions that arises directly from that. Are the health champions lay champions? Are they, and what kind of training are you giving them in the process? Several of them appear to come from churches also, which was interesting.
Yeah. So the champions actually the champions, what we decided to do is to create very, very minimal barriers to entry and very minimal expectations of what it meant to be a champion. We wanted to be as inclusive as possible. So there's no training. We give people information and we answer any question they have. We do twice weekly Zooms, which people can come on when they've got time, when they're inclined to, and we give them all of the infographics with all of the information on different aspects of navigating the pandemic. So a lot of the information around rules, around testing, tracing, isolating, but also mental health, support around all kinds of things, returning to school. And we let people do it in the way that works for them. So we've got many faith leaders from churches, mosques. They make it very, they are a champion in one way, and we have others who are champions in other ways. And it's very non-prescriptive about how they do their role. Right. With the vaccine peer supporters, there's a little bit more training, because it's a more specific defined role. So we give people a training in active listening and having supportive conversations, and also in some of the kind of the 10 top questions we get people ask about the vaccine.
There's a question obviously that arises: who's funding your programs for training the champions in vaccine? We've received funding from the government through various grants that every local authority gets, that are COVID specific grants that to support supporting our communities locally. So we there's flexibility in how we use that funds
all kinds of work from the champions through, but it also funds our local contact tracing services. It funds, we use it incredibly broadly, to fund immigration advice for some of our people with no recourse to public funds, because to me that's vital in terms of controlling infection. So yeah, we've had several million pounds from the government to support our local public health work around supporting our communities around the pandemic.
There's a question which arises from that is that are you getting proportionately higher resources than other places because of the greater need that you've illustrated?
So I am. I mean, it relates to areas, historic public health grant. I do relatively well out of that. I think other areas don't, and there is history in it that doesn't necessarily account for some of the ways in which geographies have changed and some places vulnerabilities. But I'm lucky enough that I've had sufficient resources to do most of the things that are within our control locally. Obviously, some things are just not in our control locally.
Okay, I think you're underestimating the fact that of course it requires your effort to get those amounts of money, and you mustn't underestimate that. But one obvious question is how you ensure that the budget and resources are adequate when they do compete with other council resources, between the ability to provide repairs to the pavements and traffic lights and so on. I mean, how is there sufficient locally in that context?
So, local government has faced extraordinary cuts to their budgets over the last 10 years. And, I think, other things I could have spoken about in my talk, for example, the situation with care homes and the vulnerabilities in social care. I think, you can look back at years of underfunding and say, those people in those in our care homes were laid more vulnerable, partly by kind of years of underinvestment. And the council faces constant tough choices, and the recovery challenge that we have going forward is going to be beset by difficult choices about where to invest. In the short term, I've had the resources I've needed to do what I think has been important through COVID, but that masks a much deeper long-term challenge that's put us and the community in a vulnerable place.
So you think the local authorities are going to need more resources in order to ensure that they have the capacity to cope, or do you think that it can be achieved within current health and social care budgets?
No, I mean, I think, if we're really talking about long-term recovery, if we really collectively as a society want the legacy of this incredibly hard year not to be economic and social scarring for many of our communities, I think there needs to be considerably more investment that goes into long-term to support education, to support social care, to support employment and economic recovery.
I mean, one of the questions that on what you said, one issue was the local authority and the local control of the test and the track and trace and isolation programs. Could you comment on that?
So we have done more and more. I think I said so. We got started to get the data in July, I think, and very quickly in Newham, I said, well, if we've got the data, let's be using it. And so very quickly we've developed our own contact tracing arm to do initially following up on those that NHS Test and Trace nationally were not successfully reaching. Increasingly over time, the realization became clear that actually a test and trace service that, for me, in so much of the public discussion about NHS Test and Trace, it focuses on what percentage of people are reached within what given period of time, and very little on how many actually isolate on the back of that conversation. It's kind of bean counting rather than focusing on what the point of that contact tracing service is. And we know locally that actually doing this well means building a relationship with residents around an issue that requires trust, It means understanding what barriers they face and addressing it. We do not have the money to do locally provide people with income replacement for the period of isolation. I don't personally think that any person isolating for public health grounds, not for their own personal benefit, but for the community benefit, should fundamentally face choices around how they're going to pay the rent or put food on the table. I think that's an impossible position that we're asking people to deal with, and we need to supplement people's income sufficiently. That's not something at a local level we can do. That needs government policy. But the actual contact with people, those phone calls, that building that relationship, that providing that support, more and more, I think, should be done at a local level.
Right. Okay. Now, there was the one issue that does arise. There are one or two questions about. There isn't much in that bit of East London. There isn't much of a Jewish community. It's further north. So Yiddish is not one of the languages that you've included. But are there any ethical issues about vaccines for religious communities, including Jewish communities? Religious issues as opposed to kind of ethnic issues. I know it's difficult to separate. But...
So, I mean, there have been some fears about animal products in the vaccine, and there are some, that is one of the, in the 10 questions that we get regularly asked, that's one of them. And we assure people that that there aren't, and that's not a concern. And the religious bodies, I think, across the board, the Muslim and Jewish bodies across the board have come out and said that the vaccines are kosher and halal. We are not sure how our communities are whether communities are going to consider being vaccinated as breaking the Ramadan fast. There is a differing viewpoints from people I speak to, and we're pretty sure that some in our communities will see that. So we're working with NHS colleagues to hopefully have vaccine clinics which are open at night, so that members of our Muslim community during Ramadan, which starts next month, will continue to be vaccinated through that period.
Right. I mean, that's a very, very important issue and really across a great deal of London. There was an interesting question from an American colleague who wants to know what the Nightingale are. I think the Brits might know what the Nightingale are, but there have been some insignificant announcements about the Nightingale. So maybe you'd care to comment about that.
So the Nightingale hospitals, for those who weren't aware, were or are large makeshift hospitals that were created initially in the first wave as extra intensive care capacity for the system. Really not used very much in that first wave, because by the time they were created, the peak had kind of been passed, and people interpret that in different ways. In the second wave, the Nightingale near us in East London was used as a step down facility, also to create extra capacity. They were set up by the army to create extra capacity for general hospital beds, and it was also really barely used in the second wave. With incredible ingenuity and impact on staffing, and the NHS managed to get through the peak of this wave with the beds that it had. But I mean, it was with a huge impact on staffing, and I think part of the challenge ever of using these these makeshift hospitals, was that in a system that was already struggling for staffing, who on earth was going to staff these extra units? But that was what they were.
Right, and the question about vaccine hesitancy and vaccine avoidance, and what do you think the key issues are that you've been able to succeed, and are there any other things that actually should be done that aren't being done in terms of in your area particularly?
So I definitely wouldn't say that we've yet succeeded. We are in right in the early days of the challenge, and it's going to be it's a marathon, not a sprint. We get positive feedback from our communities about our approach, about being open, honest, non-judgmental. I go out, I do this on Zoom I go on Saturday nights to Pentecostal churches and sit and answer questions from the community members to build confidence and hear people, and it's important for people to be heard and to have their questions and their concerns respected and not judged, and to create cascades and to build positive networks. So through our vaccine peer supporters, through our faith leaders, find people who feel comfortable to work with us promoting it in communities. And there's lots of them, as I keep saying, locally in our conversations, even in most of our lower uptake communities, well over half of people who've been offered so far have taken it up. So it's not, these aren't absolutes, these are relative challenges. But I also think it's about access. How much of the information inviting people to vaccine appointments has gone out in any language other than English? How many of the sites are sites that people feel comfortable and confident with? When we did pop-up clinics last week in a mosque and a Sikh Gurdwara and a Hindu temple, there were people coming to be vaccinated who could easily have been vaccinated a few weeks ago, who were eligible a few weeks ago. But actually what we had created, either because of geography or because of doing it in a place that they felt comfortable with, we'd helped to build that confidence for them. So I think it's about creating access in places that people feel comfortable, and slowly working with communities to build that confidence as well.
I mean, related to that, is there a relationship that the people access food banks and other kinds of support but don't access vaccines, or is it across the board? You find the same people not accessing food banks, worried about accepting things from the council, worried about the government finding out, worried about the government poisoning them, that spectrum. Is that apply across the board, or is it just vaccines?
There are all kinds of trust issues that many communities face. There are trust issues. There is for good reasons people who lack trust in institutions. I can't say hand on my heart confidently, that it all applies with the same people in every context. But many people have, many people do have trust issues with institutions, and I've reflected on it a lot over these last months as we've been doing since early December. It's now a few months. So many of these community conversations. I'm not a vaccine expert. I'm not a hard scientist. When I go eventually and I'm invited and I go for my vaccine, I'll be putting trust in the system which says this is safe and good for my health. But institutions have been good to me in my life. Government and other institutions have been good to me. I've got good reason to trust them. I've been reflecting a lot that for many in our communities, institutions have been less good, and there's got less reasons to trust. So that gap, that barrier that we need to support people to overcome is real, and it's meaningful, and it's therefore those trust issues exist for a reason, and it's only by really going to people and hearing them and hearing people's concerns and working in a bit of a different way that I believe that we can start to overcome some of those issues.
I think there's one other question which has arisen and which arises in quite a few people's minds before we go to let you go. And this is the question that, when you talk about mental health, you talk about the hardships that the communities face, you talk about all those things. What about yourself and your staff? What about the mental or physical or social issues that you and your staff face, and who's providing that, and is it being provided to a satisfactory degree?
Oh, what a well, I have firstly have to say that my team have been the most amazing group of people throughout throughout this whole year. Everything that I've talked about and everything I've mentioned in this talk stands on all of their shoulders. They are the most amazing bunch of people that I feel incredibly lucky to have as a team. We try and, we try to look after each other. Only earlier today, we had a session where I brought in an external coach who's been providing us support throughout the whole year. And we spent, an hour and a half checking in. How's everyone doing? How are we looking after ourselves? Reminding each other about the importance of that self-care. And so we try and look after each other, and I try and, as hard I've never worked like this in my life, like I've worked this past year. And, it's hopefully not going to have to work like this for too much longer. We spoke about it's not sustainable, but we try and support each other and try and every one of us get support from other places as well. But I think, I also recognize that this has been a hard year for everyone, and it's been hard for family, hard for me to give my children the support that they've needed through this year, as busy as I've been, and relied heavily on my partner, Mandy, who's been an amazing support to me. So we all, try and find support where we can and support each other along the way.
I think that I'll just leave it to the comments in the chat. That the comment in the chat was summarised, as you know. When I spoke to you, I mentioned that your name was mentioned by one of your colleagues in the health sector, and she used the term then that it was inspirational, and I think we've shown evidence tonight exactly that. Thank you very much.
Thank you. Cheers.
Thank you.
Good night.